Okay, you're good.
Good afternoon or good morning, whenever you're watching this. My name's Fallon Fuller. I'm Chief of Anesthesia here at the Spine Hospital. And today I want to talk about malignant hyperthermia and also a short little talk on local anesthetic toxicity and the treatments for those two episodes. First of all, I'm going to talk about malignant hyperthermia. This is our malignant hyperthermia cart that we keep in the core area in surgery. Just an overview of malignant hyperthermia, a very rare occurrence that in the literature happens about 1 in 40 to as much as 100,000 adult anesthetics. In children, much more common, 1 in 15 to 20,000 anesthetics. The vast majority of malignant hyperthermia cases happen in patients aged 19 years of age or less. So, not a common occurrence here at the Spine Hospital. How many have we had? Well, we've opened November 15th of '99. We just celebrated our 23rd anniversary 2 weeks ago. We have not had an episode of malignant hyperthermia in this hospital. We have had many patients come through that were MH susceptible, meaning mainly that they had a family member who had an episode of malignant hyperthermia, and they were told correctly to let your anesthesiologist know, or whoever you're going to operate on you know that you've got a possibility of having malignant hyperthermia. It is an autosomal dominantly inherited trait. It's genetic. If your parents have it, you have a very high likelihood of you having it. If someone says they have a brother that had it or a sister that had it, you can assume that there's a likelihood that they have it and should be treated as MH susceptible. What does that mean? That means that we give them an anesthetic avoiding the triggers for malignant hyperthermia. It's called a non-triggering anesthetic. What do we avoid? We avoid two things. We avoid inhaled anesthetics, sevoflurane, desflurane, forane, isoflurane, and we also avoid succinylcholine. We also try to do those patients first case of the day so that we can flush our anesthesia machines overnight, flush them with 100% oxygen, wash out any trace of inhaled anesthesia agent, and replace the soda line, brand new soda line. In our facility, we actually take the vaporizers off the machine so that the anesthesiologist doesn't, by muscle memory, just turn around and crack open an inhaled agent. The vaporizers are actually taken off the machine to avoid any kind of exposure to Sevo or desflurane or succinylcholine. What do we use? We use Diprovan infusion, propofol infusion, along with a non-depolarizing muscle relaxant if muscle relaxation is required. That's like rocuronium, cisatracurium, Nimbex, or ROC. You'll hear the anesthesiologist call it ROC for rocuronium. And we use those non-depolarizing muscle relaxants to paralyze the patient if necessary, avoiding succinylcholine altogether. What are the first signs of malignant hyperthermia? If you have that happen during a case, the hallmark sign is muscle rigidity, even in the face of succinylcholine on board. If the patient's given succinylcholine and their masseter spasms, their masseter muscle and their jaw spasms, and the anesthesiologist can't get their mouth open even though they just gave them a dose of succinylcholine, that is sign number one that you need to perk up and look around and make sure that there aren't other signs that are getting ready to happen that you need to start treating malignant hyperthermia. And I'll get into treatment here in a minute, but the other hallmarks of an MH episode are tachycardia, hypercarbia. This end-tidal CO2 keeps climbing even though the anesthesiologist is increasing minute volume of ventilation. They're jacking up their tidal volumes, they're jacking up the respiratory rate on their ventilator, and the CO2 is still climbing because the body can't relax. All the muscles in the body are contracting and firing and creating lactic acid, and the body's trying to blow that off, increasing CO2. You're trying to blow it off with a ventilator if you can get them intubated, and untreated, that acidosis gets worse and worse and worse, and finally leads to hyperkalemia, ventricular fibrillation, and death. Untreated, malignant hyperthermia carries about an 80 to 90% fatality rate. Fortunately, we have treatment. We have dantrolene, which is a muscle relaxant that blocks the release of calcium and lets the muscles finally relax. And if you suspect malignant hyperthermia, the anesthesiologist suspects it, we start dantrolene, 2.5 milligrams per kilo IV. And that's kept in this cart. When dantrolene first came out, it was really hard to dissolve and took forever to shake up the vials and get it into a solution to where you can give it IV. We have better preparations now that go into solution much easier. And you want to treat, you want to keep giving that 2.5 milligrams per kilo dose until the patient's symptoms subside. You're just going to keep giving it every 15 minutes. Once they've subsided, the patient goes to an ICU and they're given dantrolene every 4 to 6 hours for 24 hours in an ICU, constantly watching for this to start ramping up again. It starts ramping up again when you give it more commonly, more frequently. There are other supportive measures. If this is allowed to go on very long, you'll actually get muscle degradation and myoglobinuria that clogs up your kidneys, leads to kidney failure, as if you need a higher calcium blood level with acidosis that you're getting from all this free lactic acid building up. So we treat them with Lasix, ice cold fluids, cool off the body as much as we can. But I can tell you, until you remove the offending agent, if it's an inhaled agent, or stop giving succinylcholine and start giving dantrolene, you are getting further and further behind every minute. So the hallmarks are tachycardia, masseter spasm, muscle spasm, even in the face of muscle relaxant, increasing end-tidal CO2 despite increased minute volume of ventilation, and finally arrhythmias, acidosis, myoglobinuria, ventricular fibrillation, and death. And hopefully you don't get that far along. But The dantrolene does work. It's a miracle drug that came out in the late 80s and really, really changed the face of anesthesia and the safety of anesthesia. Before then, if you had a patient with MH, they likely didn't survive. Every operating room has this malignant hyperthermia poster, which talks about all the same signs I just described. It talks about dantrolene, how much, how often, right here, how to mix it, how to cool the patient. If you're getting a very acidotic patient, if you had to say you were in a smaller hospital and you had to wait for the dantrolene to get to your hospital. We have dantrolene here, but there are small community hospitals that can't afford to keep dantrolene around for that once in a 40-year occurrence. And so they borrow dantrolene from bigger hospitals. And if they're having to wait for it, then they're gonna have to start treating acidosis with bicarb and things like that to prevent ventricular arrhythmias. But those are all listed here. There's a phone number you can call here. They will get on the line with you during the MH crisis and go step by step with you. Are you doing this? Are you doing this? Are you doing this? And plenty of help, but it's an easily managed genetic, potentially fatal disease that is rare but catastrophic when it happens. But fortunately, we have dantrolene, and also we have non-triggering anesthetics that if we know beforehand, we can avoid any of this from the get-go. Any questions about MH?
But you might mention that the fluids are kept in that anesthesia supply room.
Oh, we do. We do have most of our IV fluids in the hospital are warmed, but we do have IV fluid refrigerator for this exact instance, and that's kept in the anesthesia workroom, Wade's room, or whatever other term you want to call it. But that's about the extent of what you need to know about malignant hyperthermia. I also want to talk today about local anesthetic toxicity, another possible occurrence that can happen in this hospital, because so many of the cases we do involve the administration of local anesthetics. Fortunately, the amount of local anesthetics given for different procedures in this hospital is not a big volume. We're operating our incisions, even our larger incisions are not, don't require a huge amount of local. But one of the things that I try to do when I'm working with a new PA or a new nurse practitioner who's gonna inject the surgical site for the surgeon with a local anesthetic, I say, okay, what are you giving? And I say, what's your toxic dose of that? And what are you gonna give should the patient have a toxic reaction to that? And if they don't know, then I ask them why in the world they would begin to think they should be giving something that they don't know how much a safe dose is, or what to do about it if they have an issue with it. And so when you start, the two main local anesthetics we use here are lidocaine and marcaine. Lidocaine, or bupivacaine, is the generic name for marcaine. There are different safe dosage levels depending upon whether or not epinephrine is added into the local. So if you have local with a vasoconstrictor, epinephrine, then you can give a little bit more safely than you could if there's no epinephrine, because the epinephrine vasoconstricts the area you're giving it in, slows the uptake of it, but you're still limited to about for lidocaine, 700 milligrams over a 24-hour period. For marcaine, no more than 400 milligrams over a 24-hour period, that you want to not go beyond. The numbers you need to remember today, since 99% of the local we give here is with a vasoconstrictor, with epi, is 7 milligrams per kilo for lidocaine and 3 milligrams per kilo of bupivacaine or marcaine. And how do you calculate what a safe dose is when you're giving the surgeon 0.25% marcaine or 0.5% marcaine? Well, right off the bat, you're only going to be able to give half as much if it's 0.5% as you would 0.25%, because it's double the strength. So what I show what I show people I'm working with on how to calculate how much it's safe to give. Basically, if you have let me erase that. That's this one?
Yep. One more. Yeah.
If you have 100% concentration, that's 1 kilogram per 1 liter of fluid. That's 100% solution. Well, obviously a 1% solution is going to be 1/100th of a kilo, which is 10 grams per liter. A 0.1% solution is going to have 1 gram per 1,000 mils, or a liter. That's going to equal about, that's 1,000. 1 gram is 1,000 milligrams per 1,000 mils, or about a milligram per mil for a 1.1% solution. So if we're given 2.5, if we're given 0.25%, 0.25% marcaine, which we typically give here, that's 2.5 milligrams in 1 mil. So if you remember any numbers off of here, remember this number right here. 0.25% marcaine has 2.5 milligrams per mil. 0.5% marcaine is going to have 5 milligrams per mil. And so you take the patient's body weight in kilos, divide that by 2.5, or actually multiply it by 2.5, and that gives you your dose that you can safely give. 2.5 milligrams per kilo is a safe dose with no epi. You can go up to 3 milligrams per kilo with epi. It also has to do with where you're actually injecting it. The highest blood levels you get are if you accidentally give it intravascularly, give it in a vein. And that's why every syringe we have in the hospital is a regular syringe, except for the local anesthetic syringe is a 3-ring syringe to enable the person giving it to aspirate, and hopefully they do, to see if they're getting blood back before they shoot it in there to make sure they're not in a vessel. And that's why it's in a 3-ring syringe, if you've ever wondered that. There is a local anesthetic technique called a beer block, where we actually put local anesthetic in the venous system to numb up a extremity. Never, ever in the history of ever should Marcaine be used in a beer block, because you can't give enough Marcaine in a beer block to work in the block that isn't a potentially lethal dose once it's released, once the tourniquet comes down and released back into the systemic circulation. That patient is going to have a Marcaine reaction, toxicity reaction, and likely not survive you dropping the tourniquet down. Only use lidocaine in a beer block. And there is an episode of when I first started practice, of a OU football player came into Baptist Hospital for a knee scope, and the anesthesiologist got the idea that, well, he didn't want to put this huge guy to sleep because he thought he'd be difficult to intubate, and he thought, well, I'll just do a beer block for his knee scope, and he used Marcaine because he didn't want the guy to hurt, but didn't realize that Marcaine could be toxic. And they let the tourniquet down at the end of the knee scope. The guy was wide awake for the knee scope, did fine the whole operation. They let the tourniquet down, and he arrested and died. So no Marcaine on a beer block. It matters where you give it. The highest blood levels are given intravenously. The second highest blood levels are on interscalene blocks between the ribs. Third highest is axillary blocks. Fourth highest would be like an epidural. Fifth highest is sub-Q. If you give it sub-Q, those are going to give you the lowest blood levels you're going to get. So it's very safe given sub-Q, as long as you're not shooting it in a vessel, and that's why we use a 3-ring syringe. The most common toxicity reaction with lidocaine is a central nervous system reaction of a seizure. That's easily treated with Versed. The most common reaction, toxicity reaction of Marcaine or bupivacaine, is cardiac arrest. That is treated with CPR and a infusion of lipids while you're doing CPR, because the lipids will bind the free local anesthetic in the bloodstream, and they'll actually begin, their heart will actually begin beating again if it isn't too long, if you haven't waited too long to do this. But you get such a profound heart block that external pacer doesn't make the heart beat, an internal pacemaker doesn't make the heart beat. Nothing makes that heart beat until you bind up the Marcaine and release the allow the signals to start passing through the Purkinje fibers, and you get a rhythm again, and your heart starts beating again. Your toxic levels of local anesthetic decrease in the environment of hypoxemia. So if you have somebody with bad congestive heart failure or bad coronaries, remember in your mind, you're not going to be able to give them near as much of a dose of Marcaine as you would somebody who's normally perfusing their normal heart. So if you're going to take care of somebody with a known history of congestive failure, you need to way back on your local anesthetic dosages. by half or a quarter of what you would normally safely be able to give. So general rules of thumb here are the only time you should ever give somebody 0.5% Marcaine is if they've specifically asked for it and you've asked them, no, wait a minute, I've got quarter ready, and are you sure you want half or you want quarter? Because the quarter, for what we're using it for basically vasoconstriction and numbing up their skin, works as well as half, 99% of the time. So there's no reason to expose them to the extra toxicity if you don't have to. If you're using a very, very small dose, like if I'm doing a spinal block or something, I might use 0.5% Marcaine because I'm given a couple of milligrams total. I don't need a whole bunch. But if I'm putting it in a intercostal block or a scalene block or a axillary block, I'm just going to use quarter with epi. Any questions? Just a word to the wise. When you're standing in an operating room or you're standing in a pain room, you have a specific job to do. There's no reason that you can't help other people at all times, and kind of up your radar and pay attention to what else is going on in the room. My own personal belief as an anesthesiologist in an operating room, nothing that happens in that room is not directly my business. Everything in there is my business because everything in there can affect my patient, and I'm wanting the safest environment I can get for my patient. And so I'm paying attention to everything that's going on. Early on in my career, by early on, I mean my first week of giving anesthesia at the VA hospital as an anesthesia resident, the chest fellow asked the circulator for 0.25% Marcaine to do an intercostal block on a man that we just took out part of his lung, and that he didn't want him to hurt as he woke up. And the circulator gave him the Marcaine, he injected it, started closing up the surgical wound. Everything was fine. We were cruising. We were getting ready to go to recovery room, and the guy suffered a cardiac arrest. And we did CPR on him for 30 minutes, including a transthoracic pacemaker, a transvenous pacemaker, including opening up his chest and doing hand compressions of his heart. And we still couldn't get him back, and we quit CPR after an hour. We didn't know about this at the time. We didn't know that the circulator had pulled off 0.75% Marcaine instead of 0.25% Marcaine that had been outlawed and was to have been taken out of every operating room in the country, but for some reason was sitting on the shelf at the VA. And I realized early on in my training, there's nothing that happens in an operating room that isn't my business. And I think it would behoove you to make that same statement for yourself, because your credentials, your license is on the line too. And if you're paying attention and you can up the safety, you can be someone else's eyes or ears and help them out and catch problems before they become problems, it makes everything safer for your patient. That's I think I'll end on that, and thanks for your time, and thanks for your care of our patients here at OSH. We appreciate you.